And then I will share my screen. Okay, you should be seeing it here in just a second. Okay. Okay. All right. Everybody see my screen? Yes, no? Yeah? Okay. Chapter 43. So hematologic and immunologic dysfunction. We'll start with this. So some ways that you're able to figure out hematologic and immunologic dysfunction most commonly are going to be by blood work. And most classically, this complete blood count or a CBC, that's going to look at all the cells individually that are within the blood. So that's going to be your key factor in diagnosing or kind of being aware that there's something going on with their hematologic system. Your physical and your history, you know, they may be pale, they may be lightheaded, having dizziness, things like that can kind of clue you into maybe something going on with their iron level or their blood counts. Kids may be being more fatigued because they're having a low hemoglobin and hematocrit because of the decreased oxygen carrying capacity and iron deficiency. They're not a great iron rich food eater, so they're not eating their red meats. They're not eating green leafy vegetables, which can worsen their iron level and worsen their hemoglobin level as well. They may be more prone to frequent infections if they have an immunologic disorder. And then obviously if they have a hematologic disorder, they may be having more prolonged bleeding or issues with clotting. Okay, so red blood cell disorders. So most commonly you think of anemia, which is low red blood cell count or a decrease in the number of red blood cells or hemoglobin. Okay. This is caused because of the decreased oxygen carrying capacity. So you're going to see these kids are going to be more pale appearing. They're going to be more fatigued and more worn out. And kind of a lot of times these kids also have lightheadedness and dizziness. Okay. Anemia is the most common blood disorder in childhood. Causes. So you'll see anemia happen in babies naturally around 6 months, breastfed babies specifically, because they're no longer having mom's iron stores in place and breast milk isn't supplying enough iron to that baby and they're not eating enough iron rich foods, you know, as they're starting solids. So you'll see that naturally happen, that those iron stores deplete around 6 months of age in breastfed babies. If they're formula fed baby, formula has added iron, so those babies are usually they don't usually have any problems. Anemia is diagnosed if a hemoglobin is less than 10 or less than 11. Okay. Typically, they might have lesser cutoffs for kids. And you figure out the type of anemia by looking at your CBC, which looks at the specific size, shape, and color of the red blood cells, and that can kind of clue you into what sort of disorder, what sort of anemia they're going to have. So you can have hemodilution anemia, so there's too much dilute that's causing the anemia. This also, anemia can be caused from decreased peripheral resistance and increased cardiac circulation from turbulence. So if they have a murmur, and they have that turbulence, or there's increased circulation, to the lungs, or it's increased circulation to the body where they're not getting that good oxygen attached to that red blood cell, you can see the anemia worsen and potentially cause heart failure. These kiddos also usually have growth retardation, so their growth is going to slow when they're anemic as well. And a lot of times they may have, if they have severe anemia, they may have signs of cyanosis. So you can see here, this is a slide that classifies the types of anemia. So increased red blood cell loss. So that would be like acute blood loss. So bloody nose, immune thrombocytopenic purpura, or ITP, DIC, hemophilia. Those are going to be your acute blood loss. So these kids are going to have that fatigue, headache, low blood pressure, decreased peripheral pulses. Okay. Increased red blood cell destruction. These kids will have dark urine. A lot of times they have frontal bossing, so more prominent forehead, and headache, and spleno and hepatomegaly. So you can have either within the cell there's an issue, or outside of the cell there's an issue. So either toxins, something like that, or an immune cause can cause an increase in red blood cell dysfunction. That'll be extra corpuscular versus intracorpuscular, which is going to be more of your hemoglobinopathies. So like your thalassemia and sickle cell disease. Okay. Your decreased red blood cell production, these kids are going to look similar to increase, but they almost always have murmur, and they almost always have pica. So if they're eating inappropriate objects, you're going to really think that this kid potentially has some sort of anemia. Usually it's a nutritional deficiency triggered type of anemia, like iron deficiency. But it may also be from a malignancy or another sort of bone marrow failure, okay, or an infection. So that's a helpful chart to know for your exam. So treatments or management of anemia, obviously for diagnosis, you're going to look at that CBC, you're going to use your history, you're going to look at your physical findings. So do they have a murmur? Are they fatigued? Are they pale? Things like that. And then obviously you're going to treat the underlying cause. So if it's iron deficiency anemia, you're going to have to intervene in their nutritional status or supplement with iron. If they have a severe anemia, then they're likely going to need transfusions. Okay. Or if it's an acute blood loss, then obviously transfusion is what they're going to need before any other supportive kind of cares or interventions. If you cannot get blood right away, then they're going to need IV fluids to replace what they're losing in an acute blood loss. And then hopefully you'll be able to get blood fairly soon and replace with blood, which is the more accurate replacer. But rapid fluid boluses is also not uncommon in a kiddo who's had blood loss. Oxygen therapy, if these kids are having cyanosis, then they're going to need added oxygen. And then bed rest to allow them to rest and recover while their anemia is being managed. So obviously, just like with any diagnoses, looking at the age of the child, the ethnic and racial background of the child, getting a good history is going to be really helpful in caring for kids with anemia. A lot of times providers will also order a blood Cult's stool test to make sure that they're not having like a GI bleed going on in addition to their anemia. So making the care age specific and kind of working with them through their management of their anemia is going to be the best thing. And as far as racial or ethnic background, sometimes, if our diet, we have a different diet than typical diet, then that can kind of worsen anemia as well. So keeping that in mind and talking with parents about that can be helpful in managing anemia. Getting those kids ready to have blood work done, because they're going to need to have routine blood work done if they have anemia, especially if it's severe anemia and they're in the hospital for that. Decrease the oxygenation needs of the tissues, so they're going to need to rest during this process, and then try to prevent complications. Okay, iron deficiency anemia. This is caused by an inadequate intake of iron. So it's usually something that's preventable or reversible by giving those kiddos their formula that's iron fortified or iron fortified cereals. Okay. And you really have to look at premature infants because they are much more likely to have iron deficiency anemia, and also adolescents because they're growing so quickly, and adolescents specifically have really poor eating habits. A lot of times they're eating on the go, so they're not eating a lot of good nutritious foods. So iron deficiency anemia is caused by different factors, but the most common cause is actually drinking too much milk, whole milk specifically. So dairy binds and replaces iron in the gut. So the more dairy that a kiddo is intaking, the worse their iron deficiency is going to be, actually. So it's helpful if you cut dairy out or cut back on it significantly. So if kids are drinking an entire gallon of milk a day, maybe they need to cut back to just 1 cup of milk a day, and that will help their iron stores. Also, eating green leafy vegetables and red meats help that as well. Pretty good prognosis for iron deficiency anemia. You may also need to supplement these kids with iron if they're a super duper picky kiddo and you can't get them to eat, veggies and meats, which is not an uncommon struggle these days with our typical American diets. Okay, sickle cell anemia. So this is hemoglobinopathy. That's probably a more common one that most all of you have heard of. So instead of having this normal, nice circular red blood cell, we have a sickled cell. So it looks like a sickle or like a scythe. So it is an abnormal or a complete or a partial replacement of the normal hemoglobin with hemoglobin S. So that sickled cell. It's an autosomal recessive disorder. Okay. So that means both parents have to have the trait. Okay. But 9% of all African Americans carry that trait. That does not mean that they have sickle cell disease. Okay. They have to get both traits from their parents to have the disease. Okay. If both parents have the trait, then 25%. So one out of every 4 kiddos that they have the 1 out of 4 chance to have sickle cell anemia. Okay. So pathophys of sickle cell anemia, this is obstructions because of the sickled red blood cells. So they build up, they block that vessel, and then anything below that blockage is not getting the oxygenation and the blood flow that it needs. So then they have vascular inflammation. And then because of the sickle-shaped red blood cells, those red blood cells are getting destroyed because they're marked as kind of like an abnormal cell in the body. And then in that area, you're going to have cellular death and hypoxia wherever that blockage is occurring. Okay. If the blockage isn't resolved, or depending on where the blockage is, these kids can have strokes. They can have blindness from retinopathy, from hemorrhage in that area. They can have splenomegaly. They can have blood in their urine. They can have necrosis of their hip. They can have a lot of different, and priapism. So they can have an extended erection if their vessels in their penis are occluded. Okay. So there's a lot of different things that can happen with sickle cell, depending on where that crisis, that blockage is accumulating. Okay. So anything that increases the body's need for oxygen or alters the transport for oxygen can potentially cause sickle cell crisis. So a trauma, infection, fever, any stressor, even an emotional stressor. So like playing in sports, sometimes that can cause them to go into crisis. So on the newborn screens, there's universally across the board a test for sickle cell disease, okay, and trait. And you can see in this picture, it's kind of hard to see a little bit, but you can see that occlusion happening here. And then everything after this occlusion is what's going to be affected. So management for sickle cell crisis, your first priority is going to be hydrating these kids. So if these kids are active in a sport, it's very, very important to make sure that they're staying very, very well hydrated, especially in the heat. Okay. Gonna have these kids rest. They're very much going to need pain management. It's extremely painful when they have these crises. So a lot of times these kids are on a PCA pump or having like, hourly or every 2-hour pain medication options, and they're usually narcotics during crises. Replacing any electrolytes, and then antibiotics if there's potential infection. And of course, if they have severe anemia, they need blood. Okay. Kids may need to be on prophylactic antibiotics after crises. It just kind of varies on the situation, but it's not uncommon for some kids with sickle cell to be on long-term prophylactic antibiotics for even up to a few years. Okay. They monitor the reticulocyte count along with the CBCs to look at the function of the bone marrow. Okay. So blood transfusion, if given very early, it may reduce the ischemia. So it might reduce that kind of occlusion and that cell death. Okay. There's no cure for sickle cell anemia except potentially bone marrow transplantation, but that even doesn't always get rid of sickle cell disease. Okay. Supportive care is prevention of sickling. So making sure that these kids stay really well hydrated, and try to keep them, living the least stressful lives as possible. And then these kids are somewhat immune compromised. So they're also going to have frequent bacterial infections. Okay. And then bacterial infections are actually the biggest cause of death in kids who have sickle cell disease. People with sickle cell disease typically live into their 50s currently, just because of the demands, the oxygenation demands that continue with these kids with sickle cell anemia. So early interventions, if they're starting to have concern for crises beginning, and then penicillin as a prophylactic, if it's ordered, monitoring for signs of stroke. So these parents are going to need to know that their kid can potentially have a stroke or a cardiovascular event. So making sure that you're educating these parents on these sort of signs. Okay. Do not restrict activity if you are able to allow that child to live as normal of life as possible is the goal. Okay. Thalassemia. So this is a common genetic disorder. It's also hemoglobinopathy. Okay. So thalassemia is also a misshapen red blood cell, but this red blood cell is going to look more rectangular instead of the sickle cell. Okay. Um, it is, there's a deficiency in the production of the globulin chain in the hemoglobin specifically. So these red blood cells, because of their shape and their impairment, they have shortened life. So these get destructed pretty easily. And it's most common in people who are from the area around the Mediterranean. There's 4 different types. So thalassemia minor, this is going to be a silent, just a carrier. They're not going to have any symptoms. Okay, thalassemia trait, they're going to have a mild microcytic anemia. Okay, thalassemia intermediate is going to have moderate to severe anemia, plus they're going to have an enlarged spleen or splenomegaly. Thalassemia major, this is probably the most common one when you think of thalassemia, you think of Cooley's anemia. And this is severe anemia, and they need transfusions of blood to survive. Thalassemia is diagnosed in the secondary part, usually of infancy, so the usually after 6 to 8 weeks of age is when it's diagnosed, but it can be diagnosed even later than that, even up to 8 months or so. They're going to have a low hemoglobin and a low hematocrit. They're going to have growth failure, so they may have been growing really well for their first few months, and then all of a sudden they start dropping off of their growth curve. And you do some blood work and you find that they have significant anemia. So these kids will get blood transfusions to maintain their hemoglobin levels. They may also need iron chelation if their iron's getting too excessive, okay? And chelation, there's drugs that they make, the desferil is one that binds with the excess iron and then excretes it through the kidney, okay? So making sure that these kids are coming in for their chelation and for transfusions as needed if they have thalassemia. These kids are going to need anxiety prevention techniques, helping them to cope with the frequent transfusions that they're going to have, okay? You as nurses will have to work with these kids and the families to adjust to the fact that this is a chronic illness that they're gonna have lifelong at this point, and that they're gonna have to come in, for multiple blood transfusions throughout their life to continue to maintain a normal, healthy life. And then you want to also encourage parents to and yourself as a nurse to observe for any complications because of all the blood transfusions that they're going to have, okay? And then this picture just shows chelation therapy. It's just removing those heavy metals from the body. Okay, prognosis of thalassemia. Usually the kids live well into adulthood as long as they're having those blood transfusions that they need and their chelation therapy. Usually they die because of after they've had their spleen removed, they get some sort of infection and get sepsis after that surgery, or they go into multiple organ failure or heart disease. Bone marrow transplantation is a potential cure, but it's not always the end all be all. Okay, aplastic anemia. So pancytopenia is the depression or the decrease in all parts of the blood, all formed elements of the blood, okay? So with pancytopenia, you're going to see profound anemia, so very, very diminished red blood cells. You're going to also see leukopenia, so decreased white blood cells, leukocytes. And you're going to also see thrombocytopenia, which is decreased platelets, or thrombocytes is the other term for platelets. Okay, so pancytopenia is the decrease or depression in all of those elements. So in your red blood cells, your white blood cells, and your platelets. Okay, hypoplastic anemia is the depression in red blood cells, but you're going to have normal white blood cells or leukocytes and normal platelets or thrombocytes. So those are all just kind of interchangeable terms. Okay. So there's congenital or primary type, which is you're born with it, or there's secondary or acquired type of aplastic anemia. So you acquire it in some way. Your diagnosis, you're obviously going to be performing a history and a physical and also obtaining lab work to diagnose aplastic anemia. These kids will need immunosuppression therapy and also bone marrow transplantation. So that way their bone marrow starts making all of these cells the way it should. The care or the management of aplastic anemia is similar to that of leukemia. So steroids and immune suppression and bone marrow transplantation. Okay. No chemo typically though with aplastic anemia because they already have diminished cells. Okay. Hemostasis, so defects in hemostasis. So dysfunction from clotting in a clotting mechanism. So one of your clotting cascades is thrown off, whether that be from a genetic condition or another pathophysiological process in the body that changes your clotting mechanisms. And vessel issue. So that vessel is having it's a narrowing or something like that can also cause hemostasis. The platelets also play a role in this. And then, like I said, your clotting factors. Okay, hemophilia. So there are multiple types of hemophilia, just like there are multiple types of thalassemia. They are hereditary and they cause specific deficiencies in specific clotting factors. Most of them are X-linked recessive. Okay. So they're going to be on that X chromosome. Okay. You have to look at the specific factor that's deficient in hemophilia to figure out which treatment is going to be effective. So hemophilia A, this is the classic kind of hemophilia you think of, and that's deficiency in factor 8. Hemophilia B, or Christmas disease, is deficiency in factor 9. And von Willebrand disease is a deficiency in von Willebrand factor and factor 8. So figuring out if a kiddo has hemophilia, you're going to get a history of this kiddo's had really, really prolonged bleeding. They've had a significant bruising or ecchymosis that they can't really explain, like, and not just normal kind of childhood bruising on the legs. It's going to be significant and all over the body. They're going to be, pushed, like somebody poked them, and they're going to instantly start having bruising like this. Or bleeding into the joints, which is the hemoarthrosis. Okay, so swelling in the joints from blood actually accumulating in those areas. Like I said, it's X-linked inheritance most commonly. You're going to have low levels of factor 8 or 9. Okay, so their PTT is going to be prolonged because they're bleeding for lengthy amounts of times. A lot of times you're going to have a normal platelet count, a normal PT or parathormone, my goodness, level is going to be normal, and their fibrinogen level is going to be normal. Okay, so therapeutic management of hemophilia, you're going to replace those missing clotting factors. Some kids may get home infusion. Some kids may go into an infusion center to get these. replacement factors. It just kind of depends on the hospital. They may or they should have at home DDAVP or desmopressin. They may get this in an IV form or a nasal spray. It causes 2 to 4 times increase in factor VIII activity. So this is really important in factor VIII specifically, deficiency. So mild hemophilia, these kids can probably manage if they get an injury and they notice that bleeding is happening or the bruising is happening and it's really significant, then a lot of times they will do the DDAVP at home and then kind of follow up with their provider after the fact. Aminocaporic acid, that prevents the clot destruction. So that kind of is also another potential management of hemophilia. So your price is going to be kind of your other piece of managing hemophilia. You're going to protect, so you're going to try to prevent injury or worsening damage to those areas, okay, wherever they've had the injury, okay. Rest, right, just like with fracture, you're going to rest. Ice in the area that they're having the pain can really help because that's going to reduce the swelling and bruising, okay. Compression is also going to help, okay, and limit the swelling, especially if there's bleeding in that joint. And then elevation of the affected area, okay. It's really important that kids with hemophilia also have good dental care, because obviously if they're bleeding every time they're brushing their teeth because they're not routinely brushing their teeth, that's going to be a concerning sign or a concerning thing for somebody with hemophilia, okay? And then genetic counseling if somebody is diagnosed with hemophilia. Mild to moderate hemophilia, most patients live pretty normal lives. May have to have some infusions every once in a while, or use the DDAVP every once in a while, but for the most part have pretty normal lives. The biggest thing is controlling the symptoms and trying to limit the joint damage, okay, to improve their quality of life and their ability to continue to do their normal daily tasks. Treatment options, gene therapy, so working on replacing those genes, that is in the works. And then, like I said, getting the factors themselves, those clotting factors that they're deficient in, okay? ITP or immune thrombocytopenic purpura. So idiopathic means that it's an unknown cause, okay? So it's also referred to as idiopathic thrombocytopenic purpura. So immune thrombocytopenia and idiopathic thrombocytopenic purpura, same thing, okay? This is an acquired hematologic hemorrhagic disorder, excuse me. Usually thrombocytopenia, so that's going to be the excessive destruction of platelets in the bone marrow and in the body, okay? And then the purpura is the petechiae under the skin. So these are going to be non-blanchable rash, okay? Non-blanchable. The bone marrow will be normal typically, but there's going to be an increased amount of immature platelets because those platelets are trying to just reproduce to try to make up for the thrombocytopenia. Okay. And you may see increased eosinophils as well. It's a self-limiting disorder. So often, usually something that happens after different viral illnesses, sometimes after strep too, but most commonly after viruses. There is a chronic version of ITP, but most of the time it's not something that's chronic, happens once, after a virus, and then it usually resolves. Okay. If it's chronic, it's lasting longer than 12 months. Okay. Treatment is mostly supportive. So if they're having any pain or discomfort, supporting that. But these kids also need to have IVIG or IV immune globulin and anti-D antibody treatments. Okay. So usually not a lot of complications. You're not going to want to do anything that potentially can cause them to bleed longer. Or so like these kids won't be having like very routine blood work or unnecessary venipunctures. Okay. You're going to want to try to have them on bleeding precautions. Okay. These kids may also get steroids at times. Okay. Okay, epistaxis or a nosebleed. This is usually a transient kind of thing. However, recurrent, you might consider that there's another reason why that's happening. So whether there's some vascular abnormalities in the nasal passages, or they have thrombocytopenia, so decreased platelets, they have a clotting disease like von Willebrand's or hemophilia, or they may have a malignancy like leukemia. Okay. When kids have nosebleeds, try to keep them calm, because if they're not calm, they're going to swallow the blood and have, a lot more complications potentially. Usually the bleeding stops within 10 minutes of applying nasal pressure to that Kesselbeck triangle. So right under that kind of nasal bridge is where parents are going to apply the pressure, and you want the child to lean forward and sit up. Okay. And then if it's not stopping after 10 minutes of holding that constant pressure, then that kiddo needs to be evaluated in the ED, because they may have some sort of clotting factor or leukemia that maybe hasn't been found. HIV/AIDS. So principal modes of transmission in pediatrics are mother to child or adolescents having risky behaviors. So having sexual promiscuity usually. So highly active antiretroviral therapy, or HAART, is the treatment regimen that helps to hopefully reduce the impact of HIV and prevent that from progressing to AIDS. Okay. So usually it's a combination of 3 or more antiviral drugs. Okay. And the goal of doing this HAART therapy is to improve the child's immune function. Okay. HIV virus can be found in blood, semen, vaginal secretions, anal secretions, and also breast milk. With the new medications out there, there has been a decreased death rate from HIV and AIDS, and also some decreased transmission. You may have seen like commercials for PrEP or things like that. So those are medications that people can take. So hopefully they're not getting HIV from their partner. And the earlier you recognize HIV or AIDS, the better the decrease in complications that you see with your patient. So in newborn infants, obviously preventing infection and improving their immune system is going to be the goal. PCP is the most common type of infection that these kids, or pneumocystic carni pneumonia. It's really opportunistic. And it typically is seen in infants between 3 to 6 months who have HIV. Okay. So education and preventative counseling with adolescents on if they do have HIV, safe sex practices, or utilizing PrEP or something like that. pain management, because HIV can be uncomfortable. And then psychosocial, these kids may need to be in therapy or something like monitoring their social status closely, because they're more at risk to, you know, kind of have some or have less friends, or feel like they're being judged because they have an HIV diagnosis. And then obviously confidentiality in any of these diagnoses, but especially in HIV and AIDS, is really important for you to follow as a nurse. So technology management of hematologic and immunologic disorders. You're going to be doing blood transfusion, so platelets or packed red blood cells, PRBCs, are probably the most common things that are given in kids with hematologic disorders. So you, as the nurse, will be monitoring for transfusion reactions and making sure you're following the guidelines for your transfusion monitoring that you should be doing. And you should be using an infusion pump for blood transfusions, okay? Apheresis, this is taking that blood out and separating the components from the blood and then reinfusing a part of the blood. So that's this machine here. That's what we use for apheresis. Usually they remove and then save platelets from healthy donors. Okay. Bone marrow aspiration, that's what this picture is showing here, is a bone marrow aspiration. So they do a tap kind of usually on the iliac crest, so that back part in your pelvic bone, and they tap that, and then they're able to aspirate the bone marrow and look at the bone marrow production. Okay, so look at the production of the blood cells in that area. It's a very painful procedure, so telling patients that it's not going to be comfortable is helpful. And also, you as a nurse will a lot of times have to help with positioning for a bone marrow aspiration, so keeping those knees to the chest, similar to how you would position a kiddo for a spinal tap as well. Okay, so letting those kids know that they might experience pain and that you as the nurse will try to manage that pain. Okay. All right, here's a question. When both parents have sickle cell trait, what's the chance that each of their child will have sickle cell anemia? So the actual disease. You guys, what was it?
A.
A. 25% chance. If both parents have sickle cell trait, it's a 25% chance that their child, that each of their children will have sickle cell anemia or disease. Good. All right, any questions on chapter 43, hematologic conditions? No? Okay, we're gonna go to chapter 44, taking care of neoplastic disorders or kids with cancer, okay? Neoplastic disorders, this is the leading cause of death in children over infancy, so over 12 months of age, okay? Almost half of childhood cancers are blood forming organ cancers, so leukemia and lymphomas are the most common neoplastic disorders in childhood. Leukemias, this is kind of a broad group. You hear leukemia, but there's multiple types of leukemia, and it's based on the bone marrow and the lymphatic system, and kind of that's how they look at diagnosing the different types of leukemia. Okay. So there's increasing complexity of classifying the leukemias now. So they look at the bone marrow and the blood work and everything to try to figure out what type of leukemia a kiddo has. Leukemia is the most common form of childhood cancer. 3 to 4 cases per 100,000 of white children less than 15. And it's more frequent in boys when it's diagnosed when they're over a year of age. Okay. Kids with Down syndrome are at higher risk for leukemia, and the peak diagnosis period is from 2 to 5 years of age. Survivability wise, though, because it is one that is studied pretty heavily, survivability is fairly good, about 95% survivable, which is huge. So the pathophysiology, so leukemia is unrestricted proliferation of immature white blood cells in the blood forming tissues of the body. So total destruction of those immature red blood cells, or white blood cells, excuse me. Okay. Liver and spleen are typically affected. And then the leukemia is going to present similarly to kids who have solid tumors. Okay. So you can see here, we're going to have more immature leukocytes. Okay. So your lymphocytes, your monocytes, your neutrophils, you're going to have more of those. Okay. Because those are your immature white blood cells. You're going to typically have less platelets. Okay. And across the board, usually you have low blood cell counts. So even your red blood cells are going to be less as well. Do a lumbar puncture to look at if there's involvement in the central nervous system. That's pretty classic in the diagnosis. And also a bone marrow aspiration or a bone marrow biopsy. And like I said, this is going to be painful. So reassuring that kiddo that you're going to help manage their pain throughout the procedure. There's 4 phases of therapy. So induction therapy is the first 4 to 6 weeks when they have the goal of putting that kiddo into remission. So totally getting rid of the leukemia is the goal for the first 4 to 6 weeks. This is when they're really aggressive with their chemotherapy, steroids, and all of that. Central nervous system involvement, they may also receive intrathecal chemotherapy to try to prevent that cancer from going into that intrathecal area and affecting the central nervous system. Intensification or consolidation therapy, this is to further eradicate any potential leukemic cells after remission. So after that induction piece, okay? So if there's any leukemic cells left, and then to prevent leukemic clones or, those leukemic cells returning. That's the next phase, which, like I said, is called consolidation. And then maintenance therapy is to preserve or to continue in the part of remission. Stem cell transplant or hematopoietic stem cell transplant, HSCT. For leukemia, this you may get autologous, which is a patient's own stem cell, or you may get allogenic stem cells, which is from a donor. Okay. Donors might be relatives, they may not be. They have to just match on certain categories to be able to donate their stem cells. They may use, so for your autologous, so your own stem cells, parents may have banked their umbilical cord so they can actually harvest those stem cells and give those to kiddos if they're in need of an autologous stem cell transplant. If the parents did not save the umbilical cord blood, then they'll need an allogenic stem cell transplant, so from a donor. It's less likely that if you have your autologous stem cell transplant or your own stem cells, you're not going to be at risk at that for graft versus host disease. But if you have an allogenic stem cell transplant, you're at risk for having graft versus host disease just because of that potential for rejection. and then obviously if you get graft versus host, it can lead to significant organ damage. Management of leukemia. So you guys are going to, as nurses, be preparing the child and the family for a procedure process that goes on when you're treating a kiddo with leukemia. So getting them ready for blood draws, getting them ready for port placements, getting them ready for the bone marrow aspirations or the spinal taps, or intrathecal chemo, all of that. You'll be preparing those children and family for that. Relieving pain. Cancer pain can be very, very significant, especially after they're given chemotherapy and they go to their nadir period, which is where all the blood cells kind of really drop, and then they have the increase back to their normal blood cell levels. A lot of times they're given injections to help those blood cell levels rebound, and that a lot of times you see limb pain. So leg pain is probably the most common complaint. Preventing myelosuppression, so trying to prevent any infections or hemorrhage or anemias. And then you as a nurse will need to you'll need to utilize chemotherapy precautions in the hospital, but you also need to teach parents about chemotherapy precautions at home. You know, if they have multiple bathrooms, if the kiddo who's on chemo can utilize their own bathroom. And then if parents are, you know, changing diapers or interacting with bodily fluids in these kids, they should be wearing gloves just for their own protection from the chemotherapy. Prognosis of leukemia, like I said, it's pretty, I mean, it's a fairly, if you have to have a cancer diagnosis, it's one that is a lot more survivable than the others. But the overall prognosis of leukemia specifically depends on your initial white blood cell count, how old you were when you were diagnosed, which cells were involved, your gender, and then your karyotype analysis, which, like I said, all of that goes into how which form of leukemia you're diagnosed with. Overall, treatment modalities for cancer, it can be a combination of surgery, chemotherapy, and radiotherapy, so radiation. Not all cancers get all three. Some just get chemotherapy, some just get radiation, and some get surgery and radiation. So there's just different variables on the type of cancer and the treatment. Surgery, obviously, the goal is to remove any portion of the tumor and restore that normal function. Chemotherapy is the primary form of treatment, so most everybody's going to get chemotherapy in some form. There's different drug combinations based on your diagnosis that are utilized, and they're given through IV, usually ports. And then precautions with chemotherapy, so you're going to have to double glove and gown and all of that. Okay. So care management. So obviously you want to provide the best quality care that you can to each kiddo while also keeping them safe. The earlier detection and the earlier treatment is critical to curing cancers. Monitoring for things like pain, fever, abnormal bruising, petechiae, spontaneous bleeding, weight loss, lethargy, overall malaise, enlarged lymph nodes. Monitoring for all of these potential side effects or symptoms from the chemotherapy and from radiation therapy as well. Vision changes can also happen from some of the chemos, so keep an eye on that as well with kids who are undergoing cancer treatments. The biggest concern in a kiddo who has cancer and is undergoing chemotherapy is infection. Okay, so you're monitoring these kids very closely for septic shock because they are going to have their neutrophil count is most likely when they're getting chemotherapy is going to be less than 100 or 500 millimeters. Okay. So watching for signs of infection and those inflammatory response is going to be helpful. Sometimes these kids are on broad spectrum antibiotics. So that your goal is to prevent infection in these kids as much as you possibly can. Hemorrhage. So these are managed with platelet transfusions. Okay. This is typically given when there's active bleeding and it's not responding to, pressure or things like that. The more conservative treatments that you can do with a kid with low platelets. Okay. Repeated transfusion does increase your risk of sensitization or forming antigens against those platelets to where there can be platelet destruction further. Because of the risk of hemorrhage with chemotherapy specifically and cancer treatments, it's best to avoid activities that may cause injury because you don't want that prolonged bleeding. And then anemia is most common during the induction phase because that's when they're getting, those big doses or the more frequent doses of chemotherapy. Okay. And then limit their physical activity based on their tolerance. Nausea and vomiting can be really intense side effect of specifically chemotherapy. So some synthetic cannabinoids are utilized in kids who are undergoing chemotherapy. So that way they are having increased appetite, their appetite being stimulated because a lot of times they're so nauseous that they won't eat. Making sure that these kids have Zofran or something like that before undergoing chemotherapy. And then usually you're doing it scheduled for at least 24 hours after completing chemotherapy. These kids, while they're undergoing chemo, they're going to have alterations in their height, weight, and their growth and their overall nutrition status. So all of those things will be monitored routinely while they're getting their therapy. High protein, high calorie, full fat versus reduced fat options because you want these kids to get as much nutrition as possible. It's also not uncommon for them to have mucosal ulcerations, ulcerations in their mucous membranes. You'll see red eroded. It'll be really painful. It can go all the way throughout the GI tract, even to the rectum. So you're going to see further worsening anorexia due to this pain. There are like magic mouthwashes that can be helpful. You do not really want to give these kids lidocaine or viscous lidocaine because of the potential for overdose. But there are mouthwashes like Carafate or Mylanta that they'll use to kind of lessen the pain from the ulceration. Sitz baths can be helpful if they have rectal lesions. So neurological problem. So you want to monitor stool habit or foot drops. I'm not sure why constipation's on there. That would be a GI problem. It's not uncommon for kids with who are on chemotherapy to have severe constipation. So monitoring their stool habits and stool softeners routinely for these kids. But as far as neurological problems, monitoring for foot drop, weakness, numbness, tingling, all of that. They may have difficulty or alterations in their gait. Jaw pain is not uncommon, and that should also be managed with analgesics, so Tylenol, and then making sure that they're drinking plenty. Hemorrhagic cystitis, so blood in their urine, is also not uncommon in kids who are undergoing cancer treatments. So they need 1.5 times average daily fluid needs. So you will see a lot of kids while they're getting chemo, they're also going to be getting fluid boluses. So monitoring for dysuria or hematuria is really important. Alopecia, that's probably the most common thing you think of when you hear about kids getting chemotherapy. Their hair is falling out in clumps. They might lose their eyebrow hair, their eyelashes. So they may want to keep their hair cut or shave their head and continue to have that be the case, throughout their treatment. Usually after chemotherapy is stopped, their hair regrows in 3 to 6 months. It may not always grow back the exact same texture or color that it was previously. So steroids are a very common part of cancer treatments. And with steroids, there's obviously the concerns for Cushing's syndrome from being on steroids. So that moon face, chunky, kind of all over looking like they're holding on to fluid because that's what's happening. They may also have what's called like a buffalo hump, so kind of like a hunchback. It can be really bothersome for older kids, especially adolescents, because think about the developmental stage that adolescents are in. They're really worried about their appearance to others. So this really bothers them when they're on steroids. To speak with parents about the potential appearance of what kids can look like when they're on steroids long term, trying to encourage them to have their kiddos wear loose fitting clothing so they're more comfortable and not eating or drinking things with a lot of salt in them to reduce the amount of fluid retention. Preparation for procedures. These kids are going to have a lot of procedures if they have cancer diagnoses. Typically, they'll be sedated for these procedures, so they won't be fully aware of what's going on. But even in that sense, they still can have the pain that goes along with a lot of these procedures that are painful. You will want to get child life involved if child life is available where you work, and explaining what's going to happen at age and developmentally appropriate levels. Okay. You're going to provide emotional support for not only the child, but also the parents. Okay. Putting on some numbing cream before they have blood draws or before you're getting into accessing their port is very important to reduce pain and anxiety with that piece. So they're going to have deeper infiltration of lidocaine because of the bone marrow biopsy. So that should help kind of with the block in that area. However, the needle to place the lidocaine is not comfortable. I don't know if you guys have ever had lidocaine injected for stitches or anything like that. It can be very uncomfortable. It stings. Pain management, a lot of times they're kids who have cancer, especially if it's pretty significant cancer, they'll be on an opiate analgesic, but obviously non-opiate analgesics are preferred. Or, you're going to assess their pain and kind of decide from there with the patient and their family. There are a lot of places that have interdisciplinary teams that decide on pain management. The doses are titrated, and then, you kind of increase or decrease based on pain management goals and to reduce the side effects. Health promotion. So kids with cancer still need their basic health care. So they still need well child checks. They still need to have regular dental visits, all of that. It kind of gets put to the wayside, obviously, because of their cancer care being kind of the priority for parents, but they should be continued to be monitoring them to make sure that they're not having any cognitive delays or emotional struggles. Okay. Like I said, dental care is still very important. And so if kids are undergoing chemotherapy or treatment for their cancer, they may not get their permanent teeth at the typical time compared to the other kids, okay? Deadened live viruses, vaccines are contraindicated. So these kids will not be getting vaccines like chickenpox vaccine. Okay. So instead, they will be getting inactivated vaccines. So they'll get the immune globulin of varicella instead of getting the vaccine. Okay. Family members, you'll want to kind of keep an eye on them too. Typically, you want to have family members be vaccinated, even if they have to get live vaccines. However, in certain situations, hematologists or oncologists may recommend that family not receive live vaccines as well if the kiddo is really immune compromised. Okay, any questions on leukemias? No? Okay, we'll move on to lymphoma. So there's two types of lymphoma, two classifications. Hodgkin's disease, which is more prevalent in like adolescent age kids, and non-Hodgkin's disease or non-Hodgkin's lymphoma, which is more prevalent in younger kids, ages 14 and younger. So Hodgkin's disease is a cancerous disease that originates in the lymph nodes, okay? So it typically metastasizes to the spleen, liver, bone marrow, lungs, and other tissues. So this is more progressive, and typically there's a lot more metastases with Hodgkin's. So these kids are going to have painless and large cervical lymph nodes. They may also have supraclavicular lymph nodes that are enlarged, so right over the clavicle. They'll have abdominal pain, decreased appetite or anorexia, cough, fever on and off, weight loss, night sweats. So if you're getting a history from a kiddo and you're hearing these things, you should be thinking of potentially Hodgkin's disease or Hodgkin's lymphoma. So diagnosis wise, similar to how you're going to look at diagnosing leukemia. So history, physical assessment, you're going to get some blood work. So look at a CBC, look at their uric acid, look at their function of their liver and their inflammation markers. So the CRP and the SID rate. You're going to look at the alkaline phosphatase too, a UA. And then a lot of times these kids are going to have x-rays. So also another part of Hodgkin's disease is they're going to get a lymph node biopsy. So you're going to actually look at what is contained in that lymph node itself. And if there's a presence of Sternberg-Reed cells, they are going to get a diagnosis of Hodgkin's lymphoma. Hodgkin's disease is usually treated with chemotherapy and radiation, but not always radiation. So it just kind of depends on their diagnosis and how progressive it is. Long-term survival is like leukemia is very excellent, especially if there's early aggressive treatment. Okay. So you're going to take care of their side effects just like you do with a kiddo who's getting radiation and chemotherapy for leukemia. You're going to support that family, and then you're going to also discuss the high risk of infertility, which can also happen from getting chemotherapy with leukemia. Okay. So you're going to have to talk to these kids about the potential risk for infertility down the road after they're getting chemotherapy and radiation. Sometimes they do like harvest eggs or do like sperm banking as well in these kids potentially. Non-Hodgkin's lymphoma, so this is more frequently in children that are younger versus Hodgkin's disease or Hodgkin's lymphoma. So this is usually diffuse, so it's kind of more all over versus in one specific spot, like the Reed-Sternberg cells in the neck and the supraclavicular lymph nodes being enlarged. So it's more all over the place. So you're going to have multiple enlarged lymph nodes. And the cell type, it's harder to differentiate. Usually it's more rapidly disseminated. And a lot of times there's involvement in the mediastinum, so in the chest is more common, where you can see the lymphoma. So you can see in this picture, stage 1 is just in the cervical lymph nodes, so in the neck, and then it kind of progresses. Stage 2 is going to be neck and then kind of axillary lymph node involvement. Stage 3 is going to be neck, axillary, mediastinal lymph node involvement, and groin lymph node involvement. Okay. And then stage 4 is going to be the cervical, axillary, mediastinal, groin, and then you're going to have some metastases, usually to the bone. So diagnosis is very similar to Hodgkin's and leukemia. So you're going to look at the bone marrow to see if there is metastasis to the bone or the central nervous system, which then that kind of mimics leukemia. So then you also need to look at CT scans and things like that to look at or biopsies potentially of those nodes to officially diagnose Hodgkin's or non-Hodgkin's, excuse me, lymphoma. Non-Hodgkin's lymphoma treatment is very aggressive, radiation and chemotherapy. You go through those phases. So the induction phase, the consolidation phase, maintenance, and some of these kids, if there's CNS involvement or concern for central nervous system involvement, they are also going to get intrathecal chemotherapy. And then the primary focus is obviously for you as a nurse to manage the effect of the chemotherapy and radiation therapy and work with the family through the process. Okay, nervous system tumors. So brain tumors are the most common solid tumor in childhood, okay? They can be either benign or malignant, okay? And there's specific cells that can be involved. So kids with brain tumors are going to present in different ways based on the location of the tumor. So they might have significant headache. They've never had headaches before, but all of a sudden they have headaches that are waking them up from sleep. And in the morning when they wake up, they have significant vomiting, anorexia. They start to have nystagmus, so their eyes start to drift back and forth. They're starting to have, arthritis kind of, or a lot of complaints of leg pain, and they're not growing as well, and they're having diabetes insipidus. So their electrolytes are all off usually, and hydrocephalus, so they have that fluid, on the brain. Diagnoses usually is based on clinical signs and symptoms, as well as getting an MRI. Lumbar punctures are contraindicated if they're having increased intracranial pressure or if there's concerns of that. So these kids may not all get lumbar punctures, okay? Biopsy is the most common way that brain tumors are diagnosed. So go in and actually take a portion of the tumor and do the diagnosis based on that. So management for brain tumors, they're going to undergo surgery, radiation, and chemotherapy. Typically, the first choice is to remove the tumor as early as possible, so that way there's no or not significant damage to the neurological system. Radio therapy or radiation therapy is to shrink the tumor before removal. So typically you get radiation and then you have surgery after that. Okay. Sometimes based on the type of brain tumor, you may just get chemotherapy by itself, or you may get chemotherapy along with radiation therapy and surgery. So after a kiddo's had surgery to remove their brain tumor, or they're having radiation, or they're having chemotherapy, you're going to monitor them for signs and symptoms of increase in intracranial pressure, looking for fluid retention, potential infections from post-op or from their operation. You're going to be doing frequent neurological assessments. You're going to be positioning them with at least their head of bed at 30 degrees, monitoring their fluids, and supporting the family and managing their pain and discomfort, okay? And also as nurses, you guys will need to be promoting them and the family also to function as optimally as they can, okay? So do as much as they can possible. Okay, neuroblastoma. So neuroblastoma is typically going to be a firm, non-tender, irregular shaped mass in the abdomen. The biggest thing with neuroblastoma, if you think somebody has neuroblastoma, or if they've been diagnosed with neuroblastoma, you do not palpate their abdomen because these tumors are so sensitive, and they flake off, and pieces of the tumor can kind of accumulate in other parts of the body. So do not palpate the abdomen of a patient who has neuroblastoma, okay? There's going to be typically neurological impairment. There can be respiratory infection or obstruction because of the tumor. They can have paralysis depending on the location of the tumor, exophthalmos, so their eyes are protruding, periorbital edema, so edema around their orbits, or supraorbital ecchymosis, so bruising around their orbits, okay? Management, so in preparing for diagnosis and the operations to remove those tumors, okay, looking at post-operative complications, so monitoring very closely for potential risks or continued bleeding, risk of infection or continued bleeding. You're going to be educating these families also about chemotherapy and radiation therapy because these kids will also be receiving those. They don't always have surgical procedures for neuroblastoma. Working on coping and providing support for these kids as well, okay? In general, osteosarcoma is the most common type of bone tumor, excuse me, and then neuroblastoma accounts for about 6% of all cancers in childhood. And neuroblastoma, the success rate is not as great as lymphoma or leukemia, okay? Bone tumors, so they are typically going to localize pain on the site that they have the tumor. Sometimes, parents or providers may say that their pain is more related to growing pains. They're going to start limping. They're going to start refusing to do activities that they usually did, or not holding heavy objects. They start dropping objects, start kind of seeming more clumsy. You may feel a mass on the bone, but you may also not. A lot of times they have intermittent fever, and potentially they can have respiratory distress depending on where that tumor is located. Bone tumors typically can be cured, so fairly good prognosis with bone tumors. You're going to diagnose bone tumors with getting a good H&P, history and physical. A lot of times these kids will have x-rays, CTs, MRIs, or biopsies of the area, looking for signs of inflammation on those studies, and then the size of the mass. A lot of times these kids will have issues with frequent infections or weight loss, anemia, very similar to the other cancers, okay? But their area of their tumor is going to affect their activity. Like I said, osteosarcoma is the most common bone cancer in kiddos. So it's usually from when the mesenchyme, the bone forming mesenchyme occurs, so in utero. It's mostly in the lower extremities near growth plates that these osteosarcoma tumors are found. Kids are going to have surgery and chemotherapy. The surgery usually includes biopsy, and they want to try to save as much of the limb as possible, but usually these kids will get some sort of prosthetic. Okay. So you can see here, this kiddo had osteosarcoma in their femur. And in order to, so they weren't able to save, it looks like, any of the portion of the femur. So they used their tibia and attached the tibia to the pelvis. So that way they have enough of a stump to be able to have a prosthesis in place. So it's actually not uncommon that they have to do things like that. Chemotherapy is used to decrease that size of the tumor. Okay, trying to salvage as much of the limb as possible is the goal. Wilms tumor, so this is a kidney tumor, painless mass in the abdomen. It's usually deeper in the flank, so kind of up on the side, but pretty deep, and usually usually on one side. Usually parents discover this like when they're helping their kiddos bathe. Okay. You know, they get the really swollen belly and they're really, it's a really firm mass. And when you push on it, it's not tender, usually. So these kids will get an ultrasound, they'll have a CT, MRI, CBC, all the blood work, and they'll also look at a UA. And they'll have signs of malignancy, but also signs of kidney damage. So it's not a great prognosis with Wilms tumor. However, it is a higher survival rate than other childhood cancers, but it's not. Usually your history is indicative of how long they've had it. And then that relates to maybe a poorer prognosis. Surgery and chemotherapy, they may need radiation as well. And your management for Wilms tumor is going to be similar to the other cancers. Okay. Usually surgery is within 24 to 48 hours of diagnosis. And then not palpating the tumor on these kids. So not palpating the abdomen is important on these kids as well. Let parents know what to expect and keep them up to date and use simple terms. Usually recovery from the surgery is fairly tolerated. And then you're going to do similar cares to what you're going to do with any sort of abdominal surgery. So monitoring for infection, monitoring bowel and bladder function. Okay, retinoblastoma. So this is a tumor that is within the retina. So you can actually see the tumor right here. So instead of having the red eye reflex, you see the tumor. So it's a whitish glow in the pupil. A lot of times these kids have strabismus, so they have lazy eye. And then if it's not caught early enough, then a lot of times they have blindness. It's usually caused by some sort of genetic alteration. Okay. But other than usually seeing that tumor or them progressing to having a lazy eye and blindness, they don't have a lot of other signs of retinoblastoma. So with retinoblastoma, they're going to get radiation therapy, chemotherapy, and then they also have to have a surgical implant of that iodine 125 for their radiation specifically. Okay. They may also undergo cryotherapy or photocoagulation. So getting a detailed history about family history of eye symptoms are important with kids who are potential diagnosis of retinoblastoma. Preparing the family for the diagnosis and how they're going to take care of that child after they have the procedure. A lot of times they have false eyes after they have the tumor removed, and then family support, just like you do with all of these cancer diagnoses. Okay, germ cell tumors are about 14% of all kids ages 15 to 19. Teratoma is the most common. So that's an ovarian tumor. Okay. Teratomas are usually within the area of the ovary, but they can be found other places as well. And teratomas have to be surgically resected. Okay. And usually they can be just removed with surgery, and people do not need to have chemotherapy or radiation. Testicular cancer, the importance of adolescent males examining their testicles to know if there's anything abnormal. So I always talk with my male patients starting at 13, 14, to make sure that they're continuing to do testicular self-exams because of the increased risk at that age of 15 to 19 of having testicular cancer. Okay. Liver tumors, so these are going to have surgical resection. That's typically done right away, and then chemotherapy after. Liver transplant is used when they cannot resect the liver. Okay. The childhood cancer survival. So on average of childhood cancers, the survival rate is about 80%. With leukemia and lymphomas having higher percentages than that, but the average is 80% for a 5-year survival rate across the board for childhood cancers. Complications are fairly common, especially when they're getting combined treatment. So they're having surgery and radiation and chemotherapy. It's more common that they're going to have complications. Changes related to those therapies, so infertility and things like that, those are later effects. If they do survive childhood cancer, those are some things that they have to deal with later in life. Okay. Monitoring their growth and their Tanner staging after they've had childhood cancer is really important, because sometimes that is delayed because of the hormone dysregulation that happens with the treatments for cancer. Radiation can cause decreased growth in bones and reproductive organs. So that furthers kind of the effects potentially. And then you are going to continue to assess all parts of the body for any abnormalities based on whichever treatment they underwent. Okay. So that is the end of our slideshow. So let's stop sharing here. So let's go to, oh, sorry, I have a couple chats, sorry. Oh, yeah, if you guys have to go to the bathroom, I'm totally okay. You can just run and go to the bathroom whenever you need to. Sorry, I should have said that earlier for those of you that aren't typically in my class. Okay. The other piece for those who aren't in my class, typically we just get out early versus taking breaks. I don't know if you guys are all okay with that. I should have asked if you're all okay with that before. Okay, so I need you guys to stay until, since we're getting out early, I need you to stay until, let's see, 20 minutes. So until 4:55 for full attendance credit, okay? And that's Eastern time. And if you're in Central time, 3:55. Okay, I'm gonna get our Kahoots going here. Does anyone have any questions on the lectures from today? I know it was a lot of material thrown at you. Like I told the students who attended my exam review, make sure you guys are utilizing the exam to review PowerPoint as kind of your study guide. So if you see something on there that you don't recognize or you don't remember reading about, then make sure you are going back and reading on that, okay? Also make sure you guys are staying on camera. I know if you run to the bathroom really quick, that's fine. You can have your camera off, but make sure you're staying on camera, okay? Like that I can see your face on the screen. Okay? Alrighty, I'm gonna share my screen here and you guys will see the Kahoots, hopefully. Okay. Are you seeing our Kahoot here now? Okay, since we're doing Kahoots as a part of class, I would like for you guys all to join. There shouldn't be any issue on capacity because I pay for the extended capacity. So please join me on the Kahoot.
How do I join?
So you can go to you can either have the Kahoot app, which takes a while to download. So I wouldn't suggest that right now. But you can go to www.kahoot, KAHOOT.it. You can either do that on your phone or do that on your computer. And then you'll just have to type this pin in. Have you guys not done Kahoot? Really? Or you have? Not really. The other thing you can do is just scan that QR code that's up there, open up your camera and like hover over the QR code that's right up here. And that should take you to the website to be able to type in the pin. Robin, were you able to get in? Or you're in the process of it at least? Okay. I will give you guys another minute or so. Also, my class, I put a handout in the week 6 information. It's a matching handout. It's really helpful. The answers are there too. I mean, I would encourage you first to try to answer as much as you can without looking at the answers, but then you have the answers there to also confirm that you're on the right track. Okay. For just terms to kind of be aware of. I'd make sure you are aware of all of those things that are on that paper for this week. Okay. There was also something like that from last week too under the announcements as well. Okay. I need a few more of you guys to join me. Okay, we'll get started. That way you guys can see these questions. Do you want me to read questions and answers? Yes. Okay. What is a priority treatment for a newborn of an HIV positive mother? The red one is to prevent transmission to others. Blue is administration of antibodies immediately. Yellow, improve the infant's immune system. Green, monitor respiratory status. That's your priority treatment for an HIV positive newborn. Yep, improve the child's immune system. HIV is an immune deficiency. Okay. So your biggest thing with a kiddo who has or is born to a mother who has HIV is monitoring and improving that child's immune system. Okay. What are the symptoms of sickle cell anemia? Red is hand and foot swelling, pain, vision problems, delayed growth. Blue is stroke, vision problems, hand and foot swelling. Yellow is hearing and vision problems, pain, stroke. Green is swelling of the hands and feet, pain, and hearing issues. Okay. Hand, feet swelling, pain, vision problems, delayed growth. Okay. That's what you're going to see with a kiddo who has sickle cell anemia. Stroke would be a complication from sickle cell anemia, not a symptom. Okay. That's why the answers with stroke were wrong. What kind of hematocrit would someone with sickle cell have and why? Lower, because sickle cells lessen red blood cell production. Higher, sickle cell causes an inflation of cells. Lower, sickle cells die faster. Or higher, sickle cells increase red blood cell production. Okay. Lower because those cells die faster. Okay. Because they're not those nice circular cells and they don't last the 120 days. They're dying more quickly. Like 60 to 90 days they may last. Okay. So your hemoglobin is going to be low in a kiddo with sickle cell disease. Okay, what's your nurse's priority with a child with sickle cell disease who is currently experiencing a crisis? Red, administer morphine 0.1 mg per kg IV, start an IV and administer a normal saline bolus. Yellow, administer antibiotics. Green, place hot packs on the swollen, painful joints. So fluids. Fluids is going to be your priority if they're having sickle cell crisis because you want to try to prevent that occlusion, that blockage. And you do that by increasing their fluid volume. Okay. Pain is going to be a part of it, but that's going to happen from that blockage. Okay. So you want to try to prevent that blockage from worsening. Any questions on that? No? Okay. What is the reason children with iron deficiency anemia are easily tired? Red is increased white blood cells. Blue is decreased red blood cells. Yellow is blood has too much plasma, or green is too many platelets. Why are kids with iron deficiency anemia tired? Yes, good. Decreased red blood cells, which means they're not carrying that hemoglobin. So they're gonna, or that, excuse me, not the hemoglobin, the oxygen and the iron on those red blood cells. Okay. Good. Okay, multiple select. The nurse is teaching about newly prescribed iron supplementation. What should be included? Take on an empty stomach, take with orange juice, drink liquid iron through a straw, inform them that it will cause their stools to turn black, take with milk, take after meals. Okay. So you don't want to take iron with food. Okay. You want to take iron with a little orange juice because the vitamin C helps the iron absorb better. You want to drink your liquid iron through a straw because otherwise the iron can stain the kiddo's teeth. Okay, so you want to try and get that iron as far back from those teeth as possible. And then iron is a really dark color. I don't know if you guys have had to take iron. A lot of times it's like a really, really dark brown or a black colored tablet. So it also turns the stools black. So telling your patients those 4 things would be included in your iron supplementation education. Okay. You don't want to take it with milk because actually that's going to defeat the purpose of taking your iron anyways, because it's going to worsen their iron deficiency. Okay, aplastic anemia includes the depression of which blood cells? Red blood cells, white blood cells, platelets, white blood cells and platelets, only red blood cells, or only platelets. Okay. Aplastic anemia is across the board depression of all blood cells. Okay. So that's happening in the bone marrow where there's suppression of all of those cells being produced. Okay. Most common type of anemia is aplastic, iron deficiency, hemolytic, or sickle cell anemia. Iron deficiency anemia. That's the most common type of anemia. Good. What caused pernicious anemia? We didn't get into this one specifically, but it's on that chart. So make sure you're looking at everything on that chart that broke down the different anemias. B12 deficiency is the cause for pernicious anemia. So it's one of those nutritional deficiency anemias. Okay. So they'll need vitamin B12 replacement. Okay. Which symptom is the single most common symptom of anemia? Fatigue, dizziness, palpitations, or tinnitus, which is ringing in the ears. Fatigue is the most common symptom of anemia. Good. When teaching parents about beta thalassemia, the nurse informs the child is at risk for hypertrophy of the thyroid, chronic hypoxia and iron overload, thrombocytopenia, or polycythemia vera. Okay, so beta thalassemia, these kids are going to have the chronic hypoxia and iron overload. These kids with beta thalassemia are going to need the blood transfusions and then iron chelation because they're getting blood transfusions frequently enough that they're getting too much iron. So then they have to have that iron chelation done. Okay. Good. What lab values will you see with hemophilia? Low platelet count. The PTT or prothrombin time is prolonged, but PT and platelet count are normal. Elevated hemoglobin and hematocrit or decreased white blood cells. Yes, good. PTT prolonged, but PT and platelet counts are normal with hemophilia. Good. So those clotting factors. What is immune thrombocytopenic purpura or ITP? Increased white blood cell count, osteoclast breakdown, bone cells, increasing calcium levels, decreased number of platelets in the blood, or deficiency in erythrocytes. Decreased number of platelets in the blood. So thrombocytopenia, the name is kind of right there in the title. Low platelets, thrombocytes. It's another term for platelets, okay? And penia is going to be low or decreased, okay? What's another term or another name for erythrocytes? You see erythrocytes on that page. What's the other name?
Red blood cells.
Perfect. Yep. The red blood cells are erythrocytes. Okay. Good. Thrombocytopenia can cause which of the following symptoms? Petechial hemorrhage, ecchymosis, and epistaxis, psoriasis, purpura urticaria, azotemia, leukopenia, hives, or anuria. Yes, petechial hemorrhage. So that's where they have the purpura or the petechiae. Okay, those are those bleeding in those tiny little capillaries. Ecchymosis, so the abnormal bruising and the bloody noses because of their low platelets. Good. Okay, multiple select. Child with hemophilia has fallen and their knee is swollen and painful. Treatment would include what? Exercising the knee, elevating the knee, hot packs, cold packs. What would you do? Yes, great. Elevate and cold packs, not warm packs. What's going to happen if you put warmth?
Dilation.
Yes, so more blood is going to accumulate in that area, and you want those vessels to constrict so the blood flow stops, hopefully. Good. What is the priority nursing action for suspected blood transfusion reaction? Stop the transfusion, return the blood bag and tubing to blood bank for analysis, administer Benadryl, obtain vital signs. Yes, stop the transfusion. That's the first thing you should do if you suspect a blood transfusion reaction. Now, you're going to probably do all these other things as well, but the very first thing you're going to do is stop it. Good. Child is admitted with neutropenia. What is your nursing action? Or which nursing action takes priority? Place the child on contact isolation, maintain strict hand hygiene, disinfect belongings brought from home, do not allow visitors in the child's room. Yes, good. Maintain strict hygiene, because if they have neutropenia, so very low neutrophils, they are very much prone to infections. Okay, and this is what happens with chemotherapy. They get a very low neutrophil count. So these kids will need strict hand hygiene and very closely monitored for infections. Okay, which symptoms would a healthcare professional expect to see in a child with leukemia? Bruising, fatigue, bone pain, dyspnea, hypotension, there's two dyspneas on that. Facial rash, abdominal pain, fatigue, hypotension, malaise, and dyspnea. Bruising, fatigue, and bone pain. Yep, that's what you're going to see with a kiddo with leukemia. Your child with ALL, so a type of leukemia, has recent labs with a platelet count of 10,000. What's your nursing action? Place on bleeding precautions, place on strict isolation, place on contact precautions, or enforce good hand hygiene. Yes, bleeding precautions, because that platelet count is very, very low, right? A platelet count of 10,000 is extremely low. Normal is like 250,000, so to 500,000. So that is very, very low. So they're very much at risk for bleeding. Good. Okay, multiple select. Child is placed on bleeding precautions for ITP. What interventions would the nurse do? No injections, monitor labs, CBC, look for active bleeding, treat with corticosteroids if symptomatic. So here are your petechiae or your purpura, okay? Yes, all four of those things. You're not going to be doing injections. You're going to be monitoring for active bleeding. You're going to be looking at their CBC to see what their blood, their platelets are doing. And then you're also going to be giving them steroids if needed. What else do kids get with ITP? What did we talk about? What's the other treatment? We're not giving these kids platelets. We're giving them IVIG, immune globulin, through their IV. Okay, good. Child with Wilms tumor, which action by a nursing student causes faculty member to intervene? Assessing urinary output per protocol, involving the parents and the child care, palpating the abdomen in all four quadrants, providing frequent nutritious snacks. Yeah, so don't palpate with Wilms tumor or nephroblastoma. Okay. Good. Child with ALL has a fever of 100.5. What should they do? Take only Tylenol every 4 hours, increase their fluid intake, get medical attention, or take an antibiotic. They have leukemia and they have a fever. Medical attention. Okay, so kids with cancer who are on chemotherapy have a fever, it's straight to the ER for them. Okay, because it's most likely that they have some sort of infection. Okay. Child is having a bone marrow aspiration. What should you tell the child? It will only hurt a little. It will be done quickly. It will hurt a little, but we will do everything to make it as little as possible, or you will feel nothing, or you will not feel anything. Yep, it will hurt, and we'll make it so it doesn't hurt as much, hopefully. Good. Most common clinical manifestation of retinoblastoma: glaucoma, cat's eye reflex, amblyopia, or sunken eye socket. Yep, cat's eye reflex. And that's where you see the tumor when you're doing your eye exam. So you shine the light and you look through, and instead of seeing that red eye reflex, you see the tumor itself. Your child has been diagnosed with retinoblastoma. What information is important? Has the child had many eye infections? History about any eye signs or symptoms seen? Does the child tear a lot? Does the child blink a lot? Yep, history about any eye signs or symptoms seen. Good. All right, a goal for surgery with a child with osteosarcoma is removal of the affected leg, salvage of the limb to use as prosthesis, remove tumor from the femur bone, or remove the femur bone. Yes, salvage the limb to use it as prosthesis. Yep. Try to salvage as much as possible. Yep, but yes, sometimes the whole femur bone has to be removed. Child is complaining about skin markings from radiation therapy. Should be told what? Markings can be easily removed with soap and water. Markings will eventually fade. Markings are caused from the radiation waves. Markings are guidelines for treatment and must remain. Yes, those markings are done to guide right where the radiation is going to be placed. Okay, so those have to stay in place while they're getting radiation therapy. Okay, when distraction is used, it helps what? Shift or move attention away from the pain. The brain focus attention on something else. Limit the amount of time spent worrying about or afraid of the pain, or all of the above. Correct, all of the above. Good. Okay, we have time for one or two more. What assessment question needs asked if a child has possible rheumatic fever? Okay, this is kind of from last week's stuff. Any sore throat or unexplained fever in the last 2 months, any nausea or vomiting, any complaints of headaches, any complaints of back pain. Yes. Sore throat or unexplained fever in the last 2 months. What's rheumatic fever known for? What has to happen prior to a kiddo getting rheumatic fever?
Strep throat.
Yep, strep. Good. Signs and symptoms of asthma. This is kind of also from last week. Coughing, shortness of breath, all of the above, or expiratory wheezing. Yep, all of the above. Let's see, is the next one going to be a respiratory question too? Multiple select. Okay, nope. What symptoms should be reported to a healthcare provider for a child with sickle cell disease? Swelling of the hands and feet, chest pain, severe headache, sores that do not heal. And this was a multiple select. Chest pain and severe headache. Why those two specifically? So if they have a vaso-occlusion somewhere, so a blockage, and they're having severe headache, what do you worry about? Stroke, right? And if they have that blockage near their heart and they're having chest pain, you worry about them having heart failure or even heart attack. Okay. Good. Okay, we'll do one more since those last two were not. Oh, this one isn't either. An absolute contraindication for nasotracheal suctioning includes which of the following? All of the above, epiglottitis, croup, or status post tonsillectomy. Which do not suction through the nose to the trachea. Yep, all of those things. Good. Any questions from anyone? No? I highly, highly encourage you all to attend a live exam review. They should all be posted in the announcements and on your calendars. Okay? Alrighty, everybody have a good day, okay? See you later.
Thank you.
Yep, you're welcome.